Hi, everyone. Welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will explore the congenital athymia treatment journey, and we're so excited to host this conversation. My name is Megan Messick, and I'm the Director of Education here at IDF. And on behalf of all of us at the Foundation, I'd like to thank you for joining us today for this Lunch and Learn and to learn more about congenital athymia. So for those of us who are new to IDF joining today, just want to share a little bit about our mission. So as an organization, we are committed to fostering a community empowered by education. And we ultimately want you guys to remember that we're committed to our community, serving as a trusted resource through the use of technology and innovation. We're here to give you the tools and information to become empowered and to offer you our compassion, our understanding, and ultimately our support to emphasize that you are not alone on your journey. So today's Lunch and Learn is a part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. Today's Lunch and Learn is also made possible by Enzyvant. Their partnership and generous commitment to our mission is truly what enables us to offer programs such as these for the PI community. We'll hear from a member of their team later on in today's program. Before we get started, I'd also like to point out a few housekeeping items to keep in mind for today's webinar. This afternoon, we are going to be using the Zoom webinar feature. So attendees should be able to see the slides and our presenter and be able to hear us both speak. Attendees, however, will not be able to activate their camera or their microphone. There is going to be an opportunity for questions after today's presentation, and you're welcome to submit any question you have for our presenter as you think of them throughout the session. We do kindly ask that questions are relevant for today's Lunch and Learn topic. Please type them in only once in the Q&A box that pops up in the control panel on your screen. Please ensure to not include any personal health information, as all of the questions will be anonymous and read out loud. I'll also share today a brief disclaimer that the information presented is not intended to be suitable for medical advice, diagnosis, or treatment. We are here today as a trusted resource and friend to provide you with information, but always seek the advice of your physician or other qualified health providers with any questions you have concerning a medical condition. Never disregard professional medical advice or delay seeking it based on the information presented during an educational event. To learn more about IDF and explore our resources, you can visit our website at primaryimmune.org. This website offers a wide variety of online and printable resources for anyone seeking information or support for PI. We can also help you find an immunologist or a PI specialist in your area using the Clinician Finder. IDF also has a growing library of resources for congenital athymia. Chapter 10 specifically of our Patient and Family Handbook is dedicated to congenital athymia and associated disorders. On our website, you can also find videos of past presentations on this topic and information on the Enzyvant Connect program. Outside of those incredible resources, we also offer monthly programming and events. We host Lunch and Learns, our bi-monthly webinars covering various topics facing the PI community. We also have Get Connected groups, peer support, Ask IDF, and our annual conference coming up this June. You can also connect with others in the PI community at our 2023 Walk for PI. We'll be in 8 cities across the US, as well as a virtual coast-to-coast walk where anyone can participate. This was something that was news to me, but did you guys know that 24 IDF research grants have been funded solely by our Walk for PI, which is absolutely incredible. You can visit www.walkforpi.org to get in on the fun and to help make a difference for our community. Thank you again for hearing about our resources. And now I am so pleased to introduce our presenter for today, Dr. Vivian Trujillo, a physician at the Allergy and Immunology Care Center of South Florida. She is an incredibly valued member of IDF's Medical Advisory Committee. Welcome, thank you so much. And I will stop sharing so that you may share your screen.
Thank you so much, Megan. It's always a pleasure to be here and to collaborate with the Immune Deficiency Foundation. Can you see my slides?
Yes.
Perfect. Okay, so today I'm going to speak about congenital athymia, which is near and dear to my heart. I've had many patients with this condition, and it's important, number one, to just explain what it is, and I'll kind of go through my slides. I have some disclosures. I've been an advisory board member for Enzyvant, Regeneron, Takeda, Pfizer, Immune ARS, and then I speak for Takeda, CSL, and then I've been a consultant with Kaleo in farming. And I think it's just important to know that I have been an advisory board member for Enzyvant. Okay, so overview. We're going to talk a little bit about what congenital athymia, how we define it, the clinical presentation of patients with congenital athymia. We're going to talk a little more in detail about genetic causes, and then about the diagnosis, how we make the diagnosis. I'll present a case study of one of my patients with congenital athymia, and then talk about management and treatment. So what is congenital athymia? Well, it's an ultra-rare condition characterized by the absence of a thymus at birth. The T cell precursors do not mature, so that leads to immune dysregulation. The immune system's not functioning quite the way it should be. And there's low T cell receptor excision circles, which are produced when T cells are produced. There's low naive T cells, and the CD3 positive T cells may or may not be low. It can also be mistaken for severe combined immunodeficiency, since both conditions can present with very low T cell counts. Patients with congenital athymia have normal numbers of B and NK cells, and then flow cytometry and genetic testing can really help us differentiate between making the diagnosis of SCID, or severe combined immunodeficiency, and congenital athymia. And here, I like this figure because it just shows the T cell precursors. If there's no thymus, think of the thymus as the tissue that is the schoolhouse. So if there's no thymus, a cell cannot become a T cell. That's really so that the thymus is the schoolhouse. Without the schoolhouse, they don't become T cells. It's also associated with multiple conditions, many of which have genetic etiology. So I'll talk a little bit about some of these more in detail in the following slides, but the frequency of underlying diagnoses have been identified in studies of patients with congenital athymia. So up to 52% can have 22q11 deletion, or TBX1 is a gene, and that's the complete DeGeorge phenotype. Charge syndrome can be up to 25%, so about a quarter of the patients. And if I think about the patients that I've cared for over the years, it does actually fall into these genetic like percentages. Diabetic embryopathy, which is when mom has diabetes and the infant is exposed in utero, up to 25%. Other causes may be 17 to 14%, and then other specific genetic causes, 3 to 9%. So let's talk a little bit more in detail about the genetic etiology. So 22q11, or complete form of DeGeorge, or 22q11, the gene is TBX1. About 50% of patients with complete DeGeorge have the deletion. TBX1 variations are believed to be the primary cause of complete 22q and DeGeorge syndrome, and 30 different genetic deletions have been seen in 22q. When we shift gears and talk a little bit about charge, the gene here is CHD7. 60 to 65% of charge can also have CHD7 variation. Then there's forms of FOXN1 deficiency, which is nude, or the SCID variation in the chromosome. And then there's gene TBX2, which is a microdeletion in a specific gene 17q23, and then otofacial cervical syndrome type 2, which is PAX1 gene. And we're going to talk a little bit more in detail about these in the next slides. So the different genetic defects, midline, so TBX1 or 22q11. I don't know, are the picture, I don't know if the pictures here are, let me move these if I can. There we go. All right. TBX1, which is 22q11 deletion syndrome, pharyngeal arch artery formation and pharyngeal segmentation. And then there's a possible role here in establishing parathyroid fate. That's why there's different, and we'll talk about how these patients present with different syndromic type features. CHD7, which is charge syndrome, again, it's pharyngeal arch artery and pouch formation is affected, and then thymic epithelial cell development as well. TBX2, the role has not yet been well defined. And then looking specifically at thymus development, FOXN1 deficiency leads to thymic epithelial cell development both pre and postnatally. And then PAX1, which is the otofacial cervical syndrome type 2, there's early expression in pharyngeal pouches and thymic epithelial cells. Okay, now we're going to talk a little more specifically about some of these different syndromic comorbidities that are associated with congenital athymia. So starting with complete DeGeorge phenotype or 22q11 deletion syndrome, the athymia is associated with immunodeficiency and recurrent severe infections. Some of the other comorbidities that are seen include, and usually the patients can be diagnosed, they have congenital heart disease, hypocalcemia as early as shortly after birth, hypoparathyroidism. They can have kidney abnormalities, hearing loss, and then palate defects or facial abnormalities. With CHARGE syndrome, they also present with immunodeficiency and recurrent severe infections. These patients are a little different. They have choanal atresia, which leads to a nasal deformity and airway obstruction in some patients, heart defects, hypothyroidism secondary to hypothalamic pituitary dysfunction, growth and developmental delay, low muscle tone, genetic hypoplasia, ear abnormalities, colobomas of the eyes, and then central nervous system abnormalities. With FOXN1 deficiency, again, it's immune deficiency and recurrent severe infections. They can have congenital alopecia and nail dystrophy. And then TBX variations, again, immune deficiency and recurrent severe infections, but the distinguishing features here include congenital cardiac defects, endocrine abnormalities, skeletal malformations, developmental delay, and craniofacial dysmorphia. When we talk about congenital athymia, there's typical and then there's atypical. So typical are low naive T cells and low TREX, which TREX are measured on the newborn screening now in all 50 states, which is very, very important to all of our patients. They have low CD3 positive T cells and low T cell proliferative response, which means they're not able to respond appropriately. Again, they have severe and recurrent bacterial, viral, and fungal infections. They can present with sepsis, which can be life-threatening. And then as far as the immune system dysregulation or autoimmunity, these patients can have cytopenias, which can affect platelets in the form of thrombocytopenia, neutrophils and neutropenia, and then red blood cells leading to anemia. They can also have autoimmune thyroiditis, and then Coombs positive hemolytic anemia. Shifting a little bit to atypical congenital athymia, they also have low naive T cells and low TREX. CD3 positive T cells may be detected, and they may have a proliferative response as well. As far as the immunodeficiency, it's also severe and recurrent bacterial, viral, fungal infections, sepsis, also autoimmunity, including the cytopenias, autoimmune thyroiditis, and the Coombs positive hemolytic anemia. And then they can also have autologous graft versus host disease, which is seen in the form of rash, lymphadenopathy. It can be enteritis, transaminitis, so increase in the liver function markers, and then pneumonitis. And we'll talk a little bit more specifically about these now. Okay, so autologous graft versus host is caused by oligoclonal T cells that have expanded outside of the thymus, and they're not tolerant to themselves. Therefore, they cannot appropriately respond to pathogens. So patients can present with what appears to be an eczematous rash and lymphadenopathy. And it's often detected in infants 3 to 8 months, but it can occur at any time. So enteritis, it can affect the gastrointestinal system, and then transaminitis, so an elevation of the liver function, can also occur. The diagnosis of atypical DeGeorge or congenital athymia, there may be a history of lymphopenia in the past, so an absence of T cells, elevated CD3 positive T cells, but low naive T cells, low TREX, again, which is what's measured on the newborn screening. The PHA stimulated T cell proliferation can be affected. Low TCR repertoire. So again, it's oligoclonal. There's few of the same. There's few, but it's of the same type. And then autologous oligoclonal T cells. The clinical implications here is there's increased immune dysregulation against self-antigens, increased morbidity and complications. And then immunosuppressive therapy here is required, but side effects from the medications can include hypertension, renal complications, or thrombocytopenia, which affects the platelets. When we look a little bit more at the differential diagnosis of the atypical congenital athymia, so again, the definition is extrathymic T cell expansion with characteristic eczematous rash and lymphadenopathy. There's a lack of thyroid development, so it can be due to congenital, genetic, or environmental factors that affected embryogenesis. The presentation is varied. It can be from diffuse erythroderma, which is the type of a rash that you saw, and like redness in the skin with scale formation, to a greasy seborrheic type dermatitis, which is what you sometimes can see in babies with cradle cap, and it can look like that. Most often it can affect the trunk, and in severe cases, it can affect the face and the extremities. And sometimes the palms and the soles can be affected. The distinguishing feature here, T cells are confirmed as host cells, so it's their own cells. They're not from maternal origin, for example. When we shift and talk a little bit about Omenn syndrome, this is an expansion of autoreactive T cells. Again, it's characterized by the erythroderma, so the redness in the skin. Hepatosplenomegaly, it can affect both the liver and the spleen. Lymphadenopathy, so increase lymph node size, diarrhea, and failure to thrive. The cause is an autosomal recessive form of severe combined immunodeficiency, usually associated with variations in RAG1 or RAG2, but there's variations in AK2, JAK3, and IL-7 receptor that have also been implicated here. The presentation is typically an eczematoid dermatosis associated with lymphadenopathy. And hepatosplenomegaly or hepatomegaly, so increased size of the liver, or splenomegaly, increased size of the spleen can also be seen. And then there's an increase in eosinophils and generalized erythroderma. Here, there's increase in peripheral eosinophils, increase in serum IgE, which is immunoglobulin E, decrease in circulating B cells, and there are decreased TREX seen on newborn screening. When we shift now to the third type, so maternal engraftment is a presence of maternal T cells in the blood. It occurs because of a persistence of those maternal cells. And then maternally derived graft versus host disease has been identified in an infant with DeGeorge syndrome. And then genetic markers are used to distinguish, so non-autologous cells, so not from the same, from the child, from autologous, which is from themselves. So the diagnosis, the T cell deficiency is usually identified. Again, thankfully, we have newborn screening now in all 50 states. So we will often see a positive newborn screen for SCID with very low TREX. On physical exam, there's two different things. So we look for syndromic comorbidities that may or may not be present. Then it's likely to be congenital athymia. If there's no syndromic comorbidities identified, it may not be. It still may be, but it may not be. Then we move on to flow cytometry. So we look at the different types of lymphocytes specifically, and we're measuring specifically T, B, and NK cells. And then again, if it's T negative, so an absence of T cells, but presence of B and NK cells, it's possible that it's congenital athymia. If we have flow cytometry where there's not an absence of T cells, then it may not be. Again, today's talk, we're going to talk about different scenarios. The most important thing, especially if it's you or if you have a child or a family member who's affected, speak to your physician, because every case and every patient is different. These are just general statements, but this is how we diagnose congenital athymia. Then genetic evaluation. So there may be a congenital athymia variant that is identified so the diagnosis can be made, there may not be a congenital athymia or SCID variant identified. And then if there's a SCID variant, then the diagnosis obviously is the diagnosis of SCID. There are other newer ways to look and kind of distinguish between SCID or congenital athymia, including artificial thymoid organoids, and these are likely to help us more as we move on in the future. I'm going to now present one of my patients who I met early in my career, actually as a resident, and I've had the pleasure of taking care of her for over 21 years. The presentation was a newborn infant with cardiac abnormalities. So she had interrupted aortic arch, patent ductus arteriosus, ventricular septal defect, and subaortic stenosis. And then she also displayed different features. So facial features, laryngomalacia, poor swallowing, gastroesophageal reflux, right renal agenesis, and low calcium that was present from birth. On flow cytometry, no naive T cells were identified. So again, this is going back over 20 years. So we did not have any newborn screening at that time. There were no TREX, but we did measure for naive T cells, and none were identified on flow cytometry, and very low PHA response that was measured around 4 months of age. And genetic testing did confirm a homozygous 22q11 deletion in our patient. Infection control measures were initiated from 0 to 4 months, so until she was able to receive a thymic implantation. She was on infection prophylaxis and immunoglobulin replacement to help prevent any infections. She received supportive care medications. And while this patient did not receive immunosuppressive medications, according to prescribing information for rethymic, which we'll talk about a little bit later, patients should receive immunosuppressive therapy prior to and or after, according to the disease phenotype. So that's just important to note. She had cardiac surgery at 10 days of age. She had an episode of sepsis, which was a severe infection at 5 weeks of age, and the G-tube was placed before her treatment. Here you can see she received her treatment at Duke at 4 months of age. She had had 2 prior episodes of sepsis at 2.5 and almost 4 months. Oh, excuse me, this is post-treatment. 5 months post-treatment, and you can see at that point she was 9.5 months of age. She had normal mitogen response, so her T cells were responding. At 1 year post-treatment, which was at 15 months of age, she had mild bilateral hearing loss that was identified, and you can see the improvement in the T cell numbers. 2 years post-treatment, so at this point she was 2.5 years, almost 2.5 years of age. She was able to discontinue the replacement of the immune globulin replacement. And shortly after 2 years of post-treatment, she did have an episode of RSV, parainfluenza, and rotavirus infection. So a triple infection with viruses. And then at present, she is just turned 23, actually, with minimal signs of immunodeficiency. Over the last 20 years, she's had some episodes of aspiration from severe reflux. She does have a hypothyroidism, so she receives replacement and has autoimmune alopecia that's related to the DiGeorge, but her numbers, as you can see here, have improved over the years. She's also working with her parents in their small business, so I have the pleasure of seeing her every so often when I visit them too. We're going to talk a little bit now about clinical management of congenital athymia. The management of congenital athymia has primarily relied on supportive care to prevent and treat infections. So we'll go through the importance of isolation, antimicrobial prophylaxis, vaccine avoidance, live vaccine avoidance, immunoglobulin replacement therapy, and then immunosuppression. So recommended for all patients, so isolation, reverse isolation with laminar airflow, surgical hand washing protocols and PPE, stop breastfeeding, and then strict at-home isolation and hygiene. For prophylaxis, antibiotic, antimycobacterial, and antifungal prophylaxis. Again, close monitoring and treatment for all infections. Vaccine avoidance, so no live or inactivated vaccines administered prior to correction of the underlying immune disorder. And then as needed blood products, which should be irradiated prior to infusion to prevent graft versus host disease. Seronegative for cytomegalovirus. Immunosuppression, so for autologous GVHD, oligoclonal expansion of the T cells, or elevated proliferative responsiveness. Immunoglobulin replacement, so that's IgG, to basically protect from infection, and since to improve the B cell function and keep them as healthy as possible. And then comorbidity, calcium supplementation, surgical repair of heart defects, tracheostomy if needed, central lines for venous access if needed, and then feeding tubes if needed. Again, these are all going to depend on each particular patient. They've looked at the burden of congenital athymia on caregivers, families, and patients. This was actually a study design that was to assess the burden of congenital athymia on patients and families. It was a quantitative survey and a qualitative interview of caregivers of patients with congenital athymia. And there were 18 participants, and caregivers were provided responses based on the experience, while children were receiving supportive care only. Here, the clinical burden, so 94% had one or more hospitalizations in the past 12 months. 72% had 5 or more different procedures in the prior 12 months. And then as far as caregiver burden, 100% were in isolation. 100% felt that there was caregiver emotional burden. 78% felt financial hardship or loss of income, and 72% were unable to meet with family or friends due to the isolation. Now we'll talk briefly about rhythymic, which is human thymus tissue that's engineered to generate a functioning immune response in pediatric patients with congenital athymia. It is FDA approved for treatment of congenital athymia. Thymus tissue is sourced from donors that are aged 9 months or less and undergoing cardiac surgery. And rhythymic is engineered in a 12 to 21 day process. The indication, again, is for immune reconstitution in pediatric patients with congenital athymia. It is not an indication for the treatment of patients with severe combined immunodeficiency. So key steps in the administration: manufacturing personnel and surgical staff prepare the rhythymic slices. It's then administered by surgical implantation into the quadriceps muscle in the thigh. Individual slices are implanted into pockets between muscle fibers, and then each implanted rhythymic slice is fully covered by muscle tissue. Following the administration, T-cell precursors from the patient's bone marrow migrate to the implanted rhythymic slices. So I said earlier, in order to have T-cells, we need thymic tissue, because that is the schoolhouse where a T-cell becomes a T-cell. And that's where they develop into naive immunocompetent recipient T-cells. Evidence of thymic function can be observed with the development of naive T-cells in the peripheral blood, but immune reconstitution, so improvement in the immune function sufficient to protect from infection, is not likely to develop prior to 6 to 12 months after treatment with rhythymic. Just looking at the survival rates, after year 1, 77% survival rate, and after year 2, 76% survival rate. And again, immune reconstitution sufficient to protect from infection is unlikely to develop prior to 6 to 12 months after treatment with rhythymic. So in summary, patients with congenital athymia have a variety of presentations. Early diagnosis is important to protect from life-threatening infections. A multidisciplinary team, and that team can be immunology, nutrition, all of the immunology, I say, there's immunologists, there may be nurse practitioners, physicians assistants, the nursing team. Everyone is important in taking part in this multidisciplinary team. Obviously, the surgical team, if they have implantation, and this is all to help address all the concerns, the multiple concerns from patients and their families. And then treatment options have expanded. I'd like to thank Enzyvant for the use of some of the slides used in the presentation, and I thank you for your attention. I'm going to stop sharing, and then we can go on to the Q&A.
Wonderful. Thank you so much. Before we dive into Q&A, we'll actually now hear from our partner, Enzyvant. I'd like to go ahead and introduce Mike Cristello, Enzyvant's Associate Director of Patient Marketing. Welcome. If you'd like to go ahead and share your slides.
Also really want to just give a tremendous amount of appreciation for Dr. Hernandez-Trujillo for what she does day in and day out to care for patients with congenital athymia, but also, for all of her patients. And we really appreciate her support, day in and day out. So again, my name is Mike Cristello. I have the tremendous appreciation and gratitude to represent Enzyvant here today, to give you all a little bit of a snippet about what Enzyvant Connect is able to offer for patients that have been diagnosed with congenital athymia, to support their healthcare providers as well as their caregivers and families. At the end of the day, there is a lot of information that was just absorbed from us that was presented by Dr. Hernandez-Trujillo. And I think that some of us may know some of that information, or maybe we found some new information today as well. But what I really like to be able to do next is give you an overview as to where Enzyvant Connect is able to support families after a diagnosis of congenital athymia. So there's a couple of different components that really are brought to the surface with what Enzyvant Connect is, our support program for congenital athymia patients, families, and their caregivers. So really what you're able to get with Enzyvant Connect is this level of support that comes in a couple of facets. So the first is a support liaison that really is able to help on a lot of that education that Dr. Hernandez-Trujillo just offered around, how the diagnosis is made, what some of the treatment options are available, and just really another voice of support that you're able to utilize that is an individual with a clinical background. In addition to that, you get an access specialist. We all know that the insurance landscape in the United States is very difficult to navigate in some cases. These folks are able to help whether you have commercial, Medicaid, or Medicare insurance benefits. They're able to help work through what your access may look like. And in addition to that, they can also provide availability of other financial assistance programs once eligibility has been confirmed. And I think, kind of speaking about eligibility, we do offer a copay program that helps with medication-related out-of-pocket costs for the treatment of congenital athymia with Thymic. And I actually am really, really grateful that I now get to do a show and tell. So there's a handful of really new materials that we've launched in the last handful of months that are available exclusively through Enzyvant Connect. So I have these kind of shown here, but I'm going to do my show and tell. So for every family that's enrolled, they do ultimately receive this wonderful caregiver organizer that is offering a multitude of items. So it's discussions about how you can have the conversation with friends and family about what congenital athymia is. There's educational resources about the actual diagnosis, as well as the treatment options that are available. Each one of these, also with the exception of the Connect Quarterly, will give you a personalized letter to the family at each step in the journey, as we've really started to talk about. These next two items are ones that I'm incredibly appreciative and proud to be able to share with you all. The first is a congenital athymia medical log. I know for me personally, when I'm going into my physician's office, I'm not the greatest about note taking. This gives you an opportunity to track appointments and the notes that you're having from a discussion standpoint with your child's healthcare provider. You can also jot down any of the lab results that are taken, from a diagnostic standpoint, and also add in a medication list, just to have a running tally of all the different items that are going into your child's care. This next one I'm going to say is probably my favorite. It's called SCID Search. It's a child storybook that we've designed exclusively with your child in mind. And it's Sadie, who is a baby T cell, and she's really just trying to find her way through the great big human body. But it's really something that is able to have a nice light feel for your child and even their siblings as well. And so as we move on to what post-treatment looks like. I know Dr. Hernandez-Trujillo mentioned, protective isolation is still going to be the name of the game in the very early stages after implantation. And so what we wanted to make sure is that we're able to do is have some fun for the family. So this is the big book of things to do activity book. So if you're like me, around my age, I recall, having highlights available in my physician's offices. So, different mazes or coloring or games that your child and your family are able to play while you're still maintaining that protective isolation. And the last item here, this is really a tremendous resource that we're able to provide to caregivers and to healthcare providers alike. It's Connect Quarterly, and we do a quarterly newsletter or webinar. So we've had one webinar, one newsletter, and I'm very excited to announce, and it actually dovetails in nicely for what Dr. Hernandez-Trujillo mentioned earlier about that burden of caregiver, kind of emotion, if you will, that she talked about earlier. So our new newsletter goes live this week. It's Self-Care for Caregivers. We have some really, really great tips, resources available. Obviously, there's a heavy thanks to our friends over at the IDF around just support groups and how you can make sure that you're getting connected with some of the other individuals that may be going through what you're going through. And so you may be asking, hey, I'm not in Enzyvant Connect. How do I get there? So it's really as simple as a phone call away. And I don't mean to sound corny with reading the headline there, but it really is. If you're wanting to seek more information, 844-369-2628. I don't mean to sound like an infomercial, but the folks over at Enzyvant Connect are a tremendous resource that can help you, from a diagnosis standpoint, from an education standpoint, from a resource standpoint. And if you're a little bit more tech inclined, feel free to use the QR code there or hop on our website at www.enzyvantconnect. But I think at the end of the day, this is a tremendous available resource to families that have had a child diagnosed with congenital athymia. Obviously, a great resource for Dr. Hernandez-Trujillo and her peers as well, to ensure that these children are getting the proper level of support and urgency around the resources that they may need. So I know I'm at about my time, and I just really want to say, on behalf of Enzyvant, myself, we really appreciate the partnership that we have with the IDF, with Dr. Hernandez-Trujillo, and what she's able to do for, children, that she's caring for that have congenital athymia. It's a tremendous amount of responsibility, and we just very much appreciate, the level of care that she offers. So thank you all. And I'm not sure if I'm giving it back to Megan or to you.
Yes, Mike, you can give it back to me, but before you hop off, we actually did just get one question specific for you, if you wouldn't mind answering for our audience. Yeah. So we got the question, has there been consideration from Enzyvant to provide counseling or therapy to the athymia families due to the mental and financial burden such extreme isolation causes on families?
I think at the end of the day, we are always continuing to evolve what our program offerings are. I know in our webinar that we had recently that had tremendous, attendance, we did get some feedback for options that we are continuing to explore. So I think at the end of the day, what I can absolutely do is take that question back to our team and see what's, the most appropriate, option for consideration. But I think, talking about the newsletter that's coming out to enrolled families in Enzyvant Connect, that is something that will be going live later this week. And I really think it'll be a tremendous resource for folks to take a look at. I hope that helps.
Thank you. Thank you so much. Now going back to our Q&A session, a friendly reminder that if you would like to ask anything during the Q&A regarding our earlier presentation, please just enter that into the box at the bottom of your Zoom screen. So I'll go ahead and read one that we have here. So one of our attendees asked, I missed the beginning of the webinar, so this may have been asked, but when did the screening for 22q 11.2 congenital athymia begin for newborns?
So the newborn screening actually is looking for TREX, right? The T-cell receptor excision circles, and that's really for SCID, severe combined immunodeficiency. And thankfully, as of December 10th, 2018, in all 50 states, the newborn screening has been in place. But the very first, I had to recheck the date. The very first state was Wisconsin back in 2008. So depending on where you live, what state you live, that really, somewhere between 2008 and 2018, thankfully, all 50 states have been screening for TREX and for SCID. I think, I'd also just like to make a comment to all the families and to the patients. When you embark on this journey, I want you to know that you're not alone. right? So we are here. And if at any point you feel overwhelmed or you have questions or you feel like nobody understands, please talk to us. Your clinical team is here to help you. When I meet patients, I tell them this is a journey and I'm on the journey with you. And I told you about one patient that I cared for who's now, she just turned 23. I have a patient who's 26 and I've known him most of his life. This is a journey and we're here to help you through it. And that's that, I think it's really important, the support that we can offer, but wherever there's support, whether it's resources from Enzyvant or there's something that you feel, this would be helpful, talk to your medical team, because we can also go back and say, look, this would be helpful for families. And I think that's really important. So if at any point you have the Immune Deficiency Foundation also, which is an excellent resource. And I think, please use the resources that are there because I feel like it can help. This is a journey and we're here to be with you.
By no means am I a healthcare provider or a physician, but I genuinely do echo the comments just made, because I think what I have found is that this is an incredibly resilient community. And, at the end of the day, we've all gone through this pandemic nearly 3+ years in the making. And I think that, there's a really great opportunity to know that there's always someone on the other end of a phone or a video call that can do their best to empathize with what you're going on or what you're going through. So I appreciate you saying that.
Yes, and I duly echo both of your sentiments about the importance of the peer connection and having a family of resources that you can access when navigating your PI journey. So thank you both for that. And that's actually the only other question that we had up. You have left them speechless with all the information you've provided. I think all of our questions actually have been answered. So I'll go ahead again and just thank you so much for being on with us today. And I will share a few more resources for those who have time to hang on, just about what's coming up from IDF. So we'll go ahead and transition to that. And if I do happen to see any more questions, I will go ahead and pull them up as well if anyone has anything last minute to add into our Q&A box. Oh, I got one. I spoke it into existence. So we did see a question here. Since you have dealt with post-transplant athymia patients, how have you seen T cell growth vary? Are there things you have seen help and support the growth?
So that's actually an excellent question. Every patient is different, right? So in some patients, the T cell growth, and I've cared for 5 patients that have had thymic implantation. All of them are doing well. But everyone, the T cells come in at different times for every patient. So I would just tell you, do I know of anything that'll help? I really don't. Keeping healthy and the isolation is important to just protect from infection, right? That's the most important. But good nutrition, I feel, is very important as well. Short of that, I think I would echo what I said earlier is, always speak to your medical team. We would all love for the T cells to be working right away. It takes time. But again, it's a journey and we're here on that journey with you. So I think that's really the most important thing.
Thank you for that. To build on that in the spirit of questions, I wanted to make sure I could plug in for you all today some additional resources that IDF has to offer. So if you later on, a couple hours from now think, there's a question I should have asked, how do I move forward from here? I want to make you all aware of our incredible resource, Ask IDF. So you can go to our website, primaryimmune.org/ask-IDF, or give us a call on the number on screen. To find resources and materials, you can also use the search function on our website or visit the IDF Resource Center, where you'll find videos, resources, podcasts, and more. We also have some really exciting spring events on the horizon. So our next Lunch and Learn opportunity will take place on May 31st. And we're excited to also share registration for this summer's Teen and Young Adult Escape Weekend is now open. So this is going to be an incredible in-person opportunity focused on our younger members in the community, and kind of to our theme and our point today, not only just providing that education, but providing that support through peer-to-peer growth and empowerment. So really incredible that we can provide that space. We'll also share lastly that our virtual PI conference, our largest event of the year, is going to be this June. You can visit primaryimmune.org/conference to register and learn more. I'm very excited about this opportunity as we have 3 incredible tracks that you all will be able to tune into this year. So we have one track that is specific to the rare of the rare and making sure that we're providing space and opportunities to focus in on a wide range of PIs. We also will be focusing on one tier that's called skimming the surface. That is information made to be accessible for those who are new to the PI community and are here to gain that foundational knowledge that's so critical on early in their journey. And we also will have a deep dive track focused on the highly nuanced, highly advanced, highly specialized for those who have maybe been in our community for many years and are looking to ask those harder questions and to get that more advanced information. So stay tuned and definitely join us for this event. Before we go, I also wanted to thank our wonderful partner Enzyvant once again for their generous support of today's program, as well as our other initiatives at SCID. And I will finish this off with one more community question that came in. I'm so happy we had another come through, which is, are there any plans to establish other transplant centers in other parts of the country?
I would just say on that front that right now we partner with Duke at the current time, and we will continue to evaluate other opportunities for thymic implantation as appropriate.
Perfect. Thank you for that. And thank you for all of us at IDF for tuning in and for being a part of our incredible community. We hope to see you at our future events.